to follow along, and you can go backwards and forwards in the slides, okay? So let me just close these ones up, and we'll go put these there. Okay, so ladies and gentlemen, I'd like to give a brief motivation for an orientation with respect to system science methods. So the context of this work, as far as I'm concerned, focuses on the fact that we as a society, we as indeed the world community, faces ever more complex health challenges. Much of this reflects progress, the basic challenges of centuries past, basic public health sanitation concerns, some of the concerns having to do with the transmission of infections of a fairly straightforward etiology, have been fairly well contained, but increasingly we're facing challenges that are more tricky in their character. These include challenges that involve interactions of multiple conditions. Perhaps it's substance abuse, violence, and AIDS, for example. In some communities, perhaps it's interaction of things like TB and diabetes. On the one hand, communicable, on the one hand, chronic metabolic disease, but their interactions are substantial because of adverse immune system impact. In some cases, we have One Health challenges, emerging infectious diseases, whether it's SARS or MERS or H1N1, swine flu, that emerge from the human-animal interface and spread, but have risks of spreading worldwide. We live in a small world that's, look at us here, a set of Canadians working in Australia. These small worlds knit us together, but they also link us as far as the epidemiology and the spread of infections. We're all too aware these days of the effects of critical periods in life, the effects of early life insults. We know from the work of Barker and others from the middle of last century just how big how big an impact early life exposures can have on later life trajectories. And studies such as the Dutch famine study, as well as work of colleagues such as Roland Dick, who's visiting Australia with us at this point as well, have clued us into the impact of utero environment and the uterine environment in shaping our future trajectories. And we know that, as we face an aging population and growing numbers of comorbid conditions, there's growing health costs and a crying need for effective prevention measures to lower the pressures on our healthcare systems. At the same time, we know that many of the actions that we've taken historically to control costs, many of the actions we've undertaken to lower public health burden have failed. Examples would be anti-tar campaigns in the US, which ended up with introduction of low-tar cigarettes, which are believed to have done net harm by causing people to not quit, but to instead switch to low tar. We know that in certain cases our use of antibiotics, while motivated by very laudable goals, has led to the emergence of antibiotic resistance, not least of it from the veterinary context. Traditional techniques here have secured tremendous insights, pathway-specific lab studies, randomized controlled trials, large-scale epi studies, and biostat studies analyzing associations between risk factors and certain outcomes. There's no doubt that these have been seminal and important foundations on which we have to build. But these pieces, these techniques are traditionally focused on understanding of the pieces. They predominantly employed a strategy which takes a system apart, examines, parcels out the risk into a set of different risk factors or a set of very specific causal pathways, a set of very specific biologic mechanisms. While this has given a tremendous amount of insight into the nature of these pieces, of particular pathways, The challenges that we face involve an additional dimension. It's not, they involve something entirely different than this, but they involve an additional dimension. And that dimension has to do with scaling up from this understanding of the pieces to an understanding of the whole. Going between what's known at the micro level, what's known at the level of specific pathways, specific risk factors, to the macro level, understanding factors at a city or regional level or indeed national level. We need to go beyond an understanding of each piece and understanding how those pieces interact effectively to yield the whole. And the fundamental realization here is that that these pieces interact in ways that are not always obvious. And if we go from condition to condition, we'll see the evidence of this. So when it comes to diabetes and obesity, we might have conceptualized it early on as largely a biomedical factor, but we know that it's nested in layers of context, which are very significant. And if we wish to change, to shape the future trajectory of the population in terms of health, we have to deal with these layers of extra context, these layers of extra causality. There's social context. There's factors having to do with the family environment, the neighborhood environment, the environment of the food regulatory environment. There's factors having to do with the layout of neighborhoods, the availability of convenience stores, etc. And if we really want to change the current situation, we can't simply look askance at these factors and say they don't fit neatly into our toolbox, but we have to really grapple with them. So, yes, there's obesity as a risk factor for diabetes and complex regulatory processes, but there's also these actors, the retailers and consumers, the agricultural industry, the weight loss industry, the city planners, who need to be brought to the table to really make a long-standing impact and to build, as Jeff says, fixes that stay fixed. We have to grapple with the role of the environment, the role that the built environment plays in the food environment in order to be able to change things on a long-term basis. And we have to deal with the fact that norms shift. And sometimes shifting norms is one of the biggest challenges in addressing the changes in behavior that they engender. We have to understand interactions with metabolic conditions that might lead to lock-in effects or might lead to long times until outcomes. Same thing with oral health. We see layers of context, context that are driven by inequities associated with dental care seeking and inequities associated with coverage for certain types of conditions. But it also links in to some degree with the food environment and the arrangement of the healthcare system. So traditional reductionist approaches have given us tremendous insights, but they provided limited insights into how these specific factors, these pieces of a system that they study so readily, combine to yield overall behavior. We observe patterns of behavior, system-wide, regional, at a level of a city, level of a neighborhood, that are not merely the results of each piece, that not merely the averages of those causal pathways or pieces, but that are emergent. In other words, they result from interactions between these factors where the whole is different from the sum of the parts. This is really important. It's almost as if we're trying to understand traffic jams on the basis of knowledge, of very detailed knowledge of car engines and car axles. Fundamentally, the knowledge needed to understand traffic jams and to resolve them boils down to a lot more than knowing about the individual features of a car or the individual features of the road on which those cars are located. It's a complex interaction of those factors. Surely it depends on something about cars, but it transcends that. It's not merely reducible to the details of the cars within the traffic jam. It has to do with driving behavior and visibility and having to do with the the patterning of the road and its turns and visibility. It has to do with the vehicles, yes, but also to the psychology of driving, etc. And so it is with much of what the challenges that faced our healthcare system. We're dealing with the equivalent of traffic jams for healthcare, and we're dealing with these emergent patterns of behavior that are more than the pieces. Okay, I won't go into this in great detail. Suffice it to say that many researchers in the health area have realized that traditional techniques need to be complemented by something that's more integrative, that puts these pieces together in a coherent whole, right? So we know that clinical trials, while they give tremendous insights, have limited direct sort of implications for how well a drug may do in society. And there's been attempts to try to address that through other means, community-based clinical trials instead of more traditional mechanisms. But in some sense, what we're controlling for in the clinical trials, compliance, adherence, the attitudes with respect to this, people's willingness to take the drug on a long-term basis, and the degree to which it really will be accepted within the society are things that often end up affecting in a large way its success in terms of changing the course of health of the individuals who take it. We can have profound understanding of physiology and immune function associated with a given disease, but that provides us limited understanding of how it spreads in the population, because how it spreads in the population is about a lot more than that. It's about contact patterns. It's about people's risk and protective behavior. It's about their willingness to seek care and to get treated, etc. We have a lot of conditions when we're dealing with these real-world policy challenges that go beyond the type of knowledge, the type of reasoning goes beyond what traditional techniques offer. And we need techniques that put those pieces together into a whole. We need to work with traditional techniques with a new set of techniques that are more integrative. So systems effects and system science is really the science of the whole. We're dealing with systems where the whole is greater than the sum of the parts. Cases where very simple components can interact to yield surprising emergent behavior that's very different from the behavior of the pieces. Now, this would be merely an interesting intellectual phenomenon were it not for the fact that when we're looking for policy success, when we're looking to secure success for interventions in a system, it's these emergent patterns that are often the key mediator for whether it's successful or not. If we're seeking to change, to lower the occurrence of traffic jams, it's not merely an intellectual exercise as to how the emergence comes about. We need to understand it so that we can change it for the better. We need to understand why we see these emergent patterns and how they can be bent so that they impose less of a burden. So when it comes to the prevalence of conditions in the population, the health burdens associated with communicable or chronic conditions, we need to understand something about where these patterns emerge from so that we can lower these burdens. Often this is a big challenge because the patterns we see in the population relate to the underlying pieces in a big way. Now, this raises challenges for two very common needs. One is to explain what's going on. If we're trying to understand, does the evidence that we have at hand support a hypothesis that we have in our head? If we want to understand where the situation is likely to go next in the absence of intervention, what's likely to play out in the next few years for the prevalence of chlamydia and gonorrhea in this population, given the rise of services such as Tinder. We need to we need to have some way to kind of parse what we see in the data. Is this a blip or is it the result of a long-term pattern? We want to understand what's driving these patterns that we're seeing. What we're seeing even is this increase in chlamydia cases. Is that the sign of something really adverse, a sign of a change in epidemiology, or is it a sign of something good, that we're actually able to bring people into the clinic on a regular basis who present for care who wouldn't otherwise be presenting? Both of those situations lead to higher reported cases of chlamydia. More infections out there, or more willingness for people to present for care. But they have very different implications for the healthcare system. So if we're trying to explain what is going on the basis of empirical evidence, and trying to understand if it's consistent with our hypotheses, we need tools. And we know, people have noted this work on the bubonic plague from the 1700s, the emergent patterns that results in the area of communicable disease. These are deaths, I think, from bubonic plague over time. And Braley had noticed this very interesting pattern that came about. That pattern is itself nothing obvious about the bacillum that causes bubonic plague. This is about how that particular bacillum combines with aspects of human behavior and mixing and patterns having to do with mortality, the mortality from bubonic plague to yield this overall curve. This is an emergent pattern. These are time series on the one hand from England in pertussis in Wales, and from Saskatchewan. They're in the same some of the overlapping years as well. And once again, we see these kind of interesting emergent patterns, these sort of waxing and waning associated with pertussis. And there's nothing about the pertussis as a pathogen that directly causes this. It's about pertussis and it's interacting with societal influences, factors having to do with when people are crowded together in schools, in this case children, when individuals are in contact with each other. It has to do to a certain degree with care-seeking behavior, but these patterns are emergent patterns. Some of the work with Christakis and Fowler has controversially highlighted the fact that there are associations, this is a Framingham heart study, associations over time as time progresses in this study, whereby individuals who have close acquaintances who are obese are themselves more likely to be obese. So there's this association which has several possible explanations, but exists even for chronic diseases. We know spatial patterning. There are pronounced spatial disparities and interesting patterns. And even in zoonoses like spreads of rabies, there are these sort of circular patterns by which the bug spreads. These patterns are structured, but they're very different from what we see in a particular component of the system. Once again, it's this entangling of many factors that give rise to these patterns. It's not just the characteristics of the bug. It's not just the characteristics of the host or the vector. It's not purely the landscape. It's not purely the other demographics of this of the populations. It's a tangling of all of those. The second major need that we have with respect to these systems that's almost universal is we want to intervene. We want to lower the burden. We want to bend the curve. We want to change the course of health. And if we're trying to understand where to intervene, it's not often obvious, particularly when we have these tangled systems. These systems where my diabetes is not just a function of purely my eating habits, but has to do with my physical activity and these layered areas of context. And if we're trying to understand where to intervene, in the case of communicable disease at the prevention level, screening level, prophylaxis level, treatment level, which target groups, how do we intervene? How soon will I see effects? How can we scale this up? What would the effects of that scale up be? How far do we have to go to hit a tipping point where we've achieved herd immunity? What do we have to do to make this implementation sustainable? We're once again grappling with systems effects. We know, that individuals who are in bridging positions between communities, this from some of our work with TB in Saskatchewan, individuals who bridge between communities are often key and key individuals in mediating the transmission. Certain infections that you would have thought would have died out would have been not fit enough to survive in the population, actually survive in network cores. And we know that in a context of populations that exhibit huge heterogeneity in terms of mixing patterns, often it's a small segment of the population, individuals with large number of partners, for example, that seem to hold the key for success at a societal level in eliminating the infection. They're the tail that wags the dog. The small group of the population that allows an infection to continue to thrive or to continue to percolate rather than dying out in the population. And we know that there are these tipping points. This has been recognized, since the work of Kermick and McKendrick in the 1920s and 1930s, predated by Ross's work in the 1910s, looking at the effects of nonlinear understanding having to do with infection transmission. So with transmission models, it was early recognized that if we could intervene just enough, if we could lower the contact rate or lower the transmission rate or shorten the duration of infection far enough, we could reach a tipping point. If we could vaccinate enough people, just enough people, we can turn the situation from a situation where someone coming into the population with the bug causes an outbreak versus where it just peters out from them, where we could secure herd immunity. Now, this very name is a suggestion of systems effects, right? You could have a population which exhibits herd immunity, and there could be susceptible people within it who are not immune, but the society as a whole is immune because it's reached a certain critical point in terms of having a low enough fraction of susceptibles. But once again, an indication of the importance of sort of systems effects that transcend the particular individuals involved and involve the broader society. Associated with this, the impacts of these interventions is this effective path dependence of reinforcing feedbacks. And I pointed earlier to an example of this, the effects of early life insults and later life prospects. The fact that what happened to me, 30 years ago is not merely forgotten in the hustle and bustle of all my later experience, but rather it has a persistent impact to my trajectory through life. That has strong impacts on our prospects for interventions that make a difference, for fixes that stay fixed. And we know that, in the context of reinforcing feedbacks, wealth breeds wealth. And if we go to the health area, so many of our interventions or potential interventions run the risk of helping the people who least need it, those who are most motivated to invest in physical activity for themselves, who have the actual luxury of time to go running in the morning rather than juggling several jobs, etc. So, when we have these complex systems, these systems where the whole is greater than the sum of the parts, we have a set of challenges. They exhibit counterintuitive behavior. They surprise us. And they surprise us when we try to intervene often. We find blowback. We find cases where our interventions have far less impact than we think they would, which is called policy resistance. Or we find that they actually have net harm that's due to them. We find that there are tipping points where if only we could position ourselves to reach that level in terms of support for physical activity or in terms of changes to the food environment, if we could remediate those food deserts to become more healthy environments, maybe we could reach a tipping point in terms of reversing the growth of obesity. When we have these complex systems, we find it difficult to unassisted learn from our experience, to coordinate the actors in the system. The parties who work on the one side in prevention, on the other side of control, often work at cross purposes. They compete for resources, they compete for attention, and they often are not as coordinated as they could be. It raises challenges for planning and deciding what to do and for designing a system. So the key point that system science grabs onto is the fact that these patterns, these emergent patterns, these patterns of these system effects, they don't arise from nowhere. They arise from underlying processes. They arise from the nature of the causal pathways that are playing out over time. They result from the mechanics of the system, in short, from the set of processes that play out over time in a dynamic fashion. Yes, these processes are tangled, but the thought from the system science perspective, particularly the dynamic modeling perspective, is that we need to reason consistently about these processes. We need to be able to hypothesize explicitly, check those hypotheses, work to validate or falsify them, and reason about them in order to have some hope of changing the situation. The challenge here, as Jeff noted, is in many ways what was pointed to 1,000 years ago by King Canute, who challenged his advisors and their claim that he could make that they could as king that he could order anything be the case. And he argued, it's not possible for me to order the tide back. The processes there are things I don't control. And he was a wise king. There's many processes that we don't control in the world. And unless we can understand them, we'll find ourselves butting our heads against the wall, working at cross purposes with them. If we can understand them, we have a chance of changing things for the better. So system science is what's sometimes called the science of the whole. That's certainly my term for it. And one of the key ways that it works is through the use of dynamic models. And these models depict, as the model you saw earlier, how things might work. They allow us to advance hypotheses as to how things might work. To think, and they serve as such as thinking tools. Laboratories for refining our thinking, for checking our thinking, for falsifying our thinking. And they help us share our assumptions with others. So there are a set of features that advise this sort of approach. And it was my intention to post this on the site, although I'm wondering if I have. If I haven't, I'll certainly try to post that later today. These are features that motivate system science approaches. Let's talk a little bit about these dynamic models we'll be spending our time with for the rest of the week. Simulation models fundamentally represent hypothesized causal relationships by which diverse factors interact over time. They are models that allow us to reason through the implications of certain hypotheses about causality and causal pathways, and allow us to kind of examine the system-wide consequences of changes in one or more areas of the system. And why do we use them? Well, they help us understand vulnerabilities, leverage points, ways of changing the structure, and ways of working together. And these go by very many names. And this is one of the points that are confusing. You'll see these sort of models broadly as a category called mathematical models or causal models, so that the latter term is confused because there's a growing set of use of that term in the area of statistical modeling. They also go by the names, let me just rattle off some. Compartmental models, agent-based models, microsimulation models, system dynamics models, discrete event models, compartmental models, equation-based models, ordinary differential equation-based models, state equation-based models. They go by many different names in different literatures. But they all have certain shared characteristics. We're going to be seeing three types. Just earlier we saw dynamic modeling predominantly in the form of agent-based modeling. There's actually a system dynamics model characterizing weight change also included in that model. But we'll introduce system dynamics a bit later in this week. And there's also discrete event modeling. All of these have certain characteristics in common. So their defining goal is to examine the dynamic behavior, the behavior over time, resulting from some hypothesized causal structure. So it allows you to say, look, I want to posit these processes as operating. Help me understand the system-wide implications of that hypothesis. Help me understand what that implies for the behavior of the parts and the system as a whole over time. These are mechanistic models. You'll hear the term mechanistic models, or models of the plumbing of the system, or models of the physics of the system. And they're called that because they depict the kind of causal mechanisms associated with the model, the posited causal structure. They depict the physics of the system that's hypothesized to be driving with a set of processes over time. Now, is that hypothesis guaranteed to be correct? No. In a capital N and a capital O. It's not guaranteed to be correct. But by building a model of this, we can more quickly identify if it's not correct than if it was in our heads. If it was just trapped in our heads, we can't easily see the implications and test if they're consistent with empirical evidence. We can't test if they're consistent with people's qualitative observations of the system. And we can't share it. By putting it into a model, we come one step closer. So how do they do this? How do they help us test it? Well, they simulate the step-by-step evolution of the system over time, the state of the system. We depict the population. We saw it earlier, right? Those individuals, those bowling balls that were moving around. Bowling pins that were moving around, right? They're representing individuals moving between different areas. We're simulating, as it takes place, this micro-world, step by step by step. In fact, in continuous time in many cases, how it evolves over time. So we can imagine, okay, this is the situation in, midsummer 2016 and late summer and early fall, late fall, etc. Now, because the model captures the posited causal structures, we can anticipate the outcomes, and this is key for counterfactual situations. The idea is by building a model which captures our posited understanding, which takes our hypothesis out of our head and puts it in a model, we can ask questions that are about counterfactuals, where we haven't actually ever observed this situation, but where it plays out based on the causal pathways we've depicted. Now, is this expectation guaranteed to be correct? No. But it may be better guess as to what's going to be happening than anything else we have, and we can cross-check it against observations empirically if we undertake an actual intervention. So these counterfactuals, this ability to examine counterfactuals, to examine situations where there is no data yet available, once we have confidence in the model, that's one of the key uses of this model. So how do we specify these models? It will differ a little bit, and it's incidentals. With discrete event modeling, we'll characterize the state of the system one way. In system dynamics, it'll be the initial values of stocks. In agent-based modeling will be where people start in their state charts and in their variable values. But we depict some initial state of the model. We provide some rules that indicate how the state will change based on its current state. So based on the current state, how is this state how will the state be changing, either probabilistically or in a deterministic way? The rates of change of the state transition hazard rates, etc. And then from that specification, the simulation will map the state of the system forward in a step-by-step fashion. Okay? So this model is going to depict the behavior of the system over time. There's going to be some evolving state. It's going to exhibit emergent behavior, patterns which we didn't program into the model, but which we have resulted from it, such as those patterns we saw earlier, deaths. There were certain features we put into the system, but certain features which actually emerged from it. So we put in certain things, but these patterns here, these were emergent. We didn't program them into the system. They simply were imposed, they simply came out of the system over time. And generally, these are nonlinear models, so those emergent patterns exhibit features which are often very surprising and very different from the underlying situations. Now, in health, these techniques are largely new. I've been working in this area for health for about getting close now to 20 years. But when I first started, these techniques were outre. They were edgy. They were on the edge. Now they're of central interest in certain spheres within health, including many with great deal of interest in population health. Certainly for infectious disease, they've been used for better part of a century now, quite centrally. But in many other areas of health, they're really picking interest. And they're familiar territory in many other areas of societal investment, whether it's training people for power plants or for driving or for street design or for climate policy. These models are central to the discourse. So these models fundamentally, okay, thank you, Jeff. These models fundamentally serve as thinking tools, thinking prostheses. They help us learn more quickly from the empirical evidence by thinking through the implications of our assumptions. And by taking it out of our head and putting it into model, they help us think it through more deeply, reliably, and quickly than we could if it were in our heads. And thereby allow us to put our empirical evidence to better use, to more complete use, more effective use in shaping our understanding, to advance our understanding. So they're best used by having some hypothesis in our mind, capturing it in our model, observing the consequences from the model, using that to further test, refine our theories, motivate the collection of data or the undertaking of interventions, observe the results, cross-check the model, and further refine our learning. So this is a learning loop, ladies and gentlemen. It's a learning loop that helps us more quickly falsify our hypotheses about the world by testing their consistency with empirical evidence. And without a model to bring together this with the emergent results, it would be hard to falsify our hypothesis about the world that's being captured in the model. By having a simulation that tells us the consequences of these assumptions, it helps us more quickly debug that thinking. So I'm fond here of quoting Francis Bacon. And perhaps someday Jeff will, in a stentorian voice, be able to pronounce the Latin there. But Francis Bacon once said, "Truth will come sooner out of error than from confusion." And that sounds like an outrageous statement. How can it be that by making an error that we're further ahead than just being confused? Well, this was Francis Bacon's way of saying in the 1500s, 1600s? 1600s? 1620? Thank you. 17th century. It was his way of saying fail early, fail often. Look, sitting back and being confused about it is not all that helpful. If we try something, we posit a theory and we test it, we're further ahead because we'll discover the error sooner and we'll be able to refine our theory. So it's better to sort of go out and try something and be proven wrong. At least you've gotten somewhere compared to just sitting back and being confused. So it's better to be transiently wrong than perpetually confused, in short. That's the thinking behind these models. Models are learning tools. They're not crystal balls that when they're proven wrong, they shatter and have no value. They are tools that when they're proven wrong, we have learned something. We have learned something about the world that refines our understanding. Okay? Now these models are put to many uses. Josh Epstein and Don Burke at Pitt, Josh at Hopkins, have enumerated dozens of uses of these models. I've just listed a few here. Perhaps the deepest is they make explicit our thinking so that we can share it, so we can refine it. So I can put it out there and you could say, no, you're off in this, or this has been shown to be an outdated theory. We have a much better understanding of this causal pathway now. That's something that might not have happened if I had just kept it hidden in my head. They can help us learn faster and more deeply from evidence. I've just been emphasizing that. But they can help in management of these systems, help us ask what-if questions about counterfactuals, to identify policies that are high leverage, that are robust, that help enhance, lower the health burden, but are also cost effective, get greatest bang for the buck, that are robust in light of uncertainties. They can help evaluate the benefits of restructuring a system and help us understand trends. They can also help us prioritize data collection by pointing us to certain uncertainties that are particularly key, that are particularly to which the model's implications are particularly sensitive. And understand classes of context where we could take the learning from one set of observations and bring it to the other. To what degree can we take learning that has gone on in Sydney and bring it to Dubbo? Or to what degree can we take learning that's gone on in Los Angeles and bring it to Canberra? They can help us sort of figure out how to adapt or how to scale or how to adjust interventions. Okay. The other analogy I just want to introduce here, and I'm painfully aware of separating you from your food, so I'll be finishing up here in a minute, is that models are like maps. Models like maps are abstractions of the world. They depict a simplified view of a complex world. Both omit lots of details. And maps are made useful by their omission of details. So if we want to drive through Sydney, I'll use one type of map. If I want to cycle through Sydney, I'll use another. If I want to take the buses and trains through Sydney, I'll take a different type of map. And each of those maps is useful, but it's an incomplete description of Sydney. It's incomplete. It leaves out all sorts of details. But models are similar in the sense that we leave out detail, and in part they're useful because we leave out detail. But what detail we leave out for both models and maps is specific to the purpose of the model. Both can be useful while leaving out a lot of detail for certain purposes, but it would be a grand problem if I wanted to fix a problem with brownouts in Sydney, electrical failures, and I tried to use a transit map. It wouldn't offer me much help. I'd really want an electrical connectivity map of the city, or if I wanted to fix flooding in the city. It wouldn't be very good if I had a bicycling map only. So models, like maps, are wrong in the sense that they're an incomplete description of the situation, but their very incompleteness is sometimes what allows them to offer practical value. Now, the caution here is with models, it's more difficult to ascertain a priori what information should be omitted. But we're always dealing with an incomplete hypothesis, a hypothesis that doesn't include all the details. And all models like this include three types of categories. Some categories that are endogenous, that are simulated within the model. These are variables that over time the model generates for us. It tells us the value of these quantities. There's another set of things that are represented in the model, but we've told it what to assume over time or in a fixed way for these. We call these exogenous things. So we tell it what to assume for exogenous things. It generates the endogenous things. They're the result of simulation over time. So in this model that we're depicting here, the fraction of the fraction of meals that a person eats, and in fact their weight over time, those are endogenous factors. Those are generated by the model. We tell it for a given person what to assume for their weight initially, but after that, that weight is evolving according to the vagaries of the model processes. So that's an endogenous thing. By contrast, the assumption, for example, to make about the amount of energy intake to assume from a convenience store meal or a supermarket meal, those are exogenous factors. I tell it, assume this, assume that. Sometimes this is fixed, sometimes it's a time series. The point is it's pre-specified by us. And then there's some factors that are simply left out of the model, often consciously left out. We do so with recognition. We may add them in later, but right now we're not sure that they're needed for our hypothesis that we wish to test. And over time, we can add more endogenous factors, but there's cost to that in terms of power and accuracy. Okay, I think I'm going to stop here so that you can get some food that's now been catered. And we will next dive into a set of models. I'm gonna use the balance of the morning to go through in a hands-on way, exploring and running and modifying here and there a set of models. This afternoon, we're going to jump into building some of our own models. Okay, but this morning we're going to explore some of the diversity of models that that I provided you, so that you can get a sense of many of the building blocks of any logix model building toolkit. Okay, that's it. Thank you very much.
Toilets are down the end this way, and the food's next door.